So next is testicular cancer, v45. As a surgeon on call, you admit a 25-year-old lad with confusion, shortness of breath, and abdominal mass. Your keen junior mentioned that on examination, his right testis is hard. A chest X-ray shows multiple lung mets. You confirm that there is a suspicion hard testis on the examination. What are your key points in the history? So symptoms and duration: 10% present with metastatic symptoms. Risk factors for testicular cancer: undescended testes, family history, HIV, history of testicular germ cell neoplasm, which could be secondary to cryptorchidism, extragonadal germ cell tumors, previous or contralateral testicular cancer, atrophic contralateral testes. Does the patient have children, and has he completed his family? What investigation would you order? Also, after confirming clinical findings of testicular cancer, I would examine the state of the contralateral testes. Assessing the consistency and volume, I will arrange routine blood tests with inclusion of serum tumor markers, AFP, HCG, LDH, chest X-ray, and CT scan of the chest, abdomen, and pelvis. Based on the clinical history of confusion, I would also arrange a CT head. What tumor markers are used to diagnose the testicular cancer? Alpha-fetoprotein, which is raised in non-seminomatous germ cell tumors. HCG expressed by 100% choriocarcinomas and 40% teratomas, 30% seminomas, and LDH marker for tumor burden and staging. If his imaging confirm a testicular tumor with no evidence of metastatic disease, how would your management be? The radical inguinal orchidectomy with discussion about the prosthetic insertion, and consideration should be given to the sperm banking if this is solitary testicle and low volume. How would you perform the procedure to remove his testicle? I would perform the procedure under general anesthetic on an appropriately consented and prepared patient. I would identify landmarks including anterior superior iliac spine and pubic tubercle. I would then perform the procedure via an inguinal incision. Opening the external oblique from the ring and tie with, I would dissect the cord up to the deep inguinal ring, transfix the remaining stump with heavy zero suture, removing the testicle spermatic cord and covering intact. What would your management plan if the CT showed derivative abdominal mets and raised tumor markers? Most low to intermediate stage tumors can be managed by orchidectomy, followed by staging and then chemotherapy. However, in stage 4 disease presenting with distant metastatic disease, the treatment is with neoadjuvant chemotherapy followed by surgery.